Dr. Daver, what treatment strategies are available for high-risk AML patients?
High-risk AML patient includes a group of number of different mutations and cytogenetic abnormalities. This includes TP53 mutation, as well as adverse cytogenetics, which includes chromosome 17, deletion 5, deletion 7, as well as complex karyotype. This entire group is historically had a poor outcome and has had limited responses to traditional intensive chemo. And even if we achieve responses, they're usually short-lived. We do have some patients where we're able to achieve remission with intensive chemo or with azacitidine venetoclax and transition them to transplant, with about 25-30% potentially achieving a long-term remission and possible cure. But aside from that, there is very little potential to cure these patients with just traditional intensive chemo or HMA venetoclax. In this area, there has been developments with the emergence of a new class of immunotherapy drugs called the CD47 antibodies. The one that is most advanced in this field is a drug called magrolimab. And we are evaluating the drugs such as magrolimab in combination with azacitidine, as well as in combination with azacitidine venetoclax, and are seeing high remission rates, both in TP53 mutated and in TP53 wild type. So this pathway that works by activating the macrophages or the immune system to attack the tumor cells seems to be in some way mutation agnostic, with response rates being maintained even in the traditional high-risk subsets, especially such as TP53 and complex cytogenetics. For some of the other high-risk groups, such as MLL, we're using targeted therapies like menin inhibitors, and these seem to work well in those patients who have these adverse cytogenetic molecular abnormalities. So there is progress, and we think that the CD47 antibody field and hopefully the menin inhibitor field will be able to improve outcomes in these traditionally high-risk molecular cytogenetic subsets. My activation point related to this question is that for high-risk mutations and cytogenetic abnormalities, such as TP53, complex karyotype, chromosome 17, MLL, the best hope at this time is in clinical trials evaluating novel therapies such as CD47 antibodies and menin inhibitors. These are not yet FDA approved, but based on emerging data from the ongoing phase 1-2 studies, we think that there is a good chance they will be approved in the future. However, at this time, the best way to get to these agents is to go on clinical trials and incorporate these therapies both in the frontline setting as well as in the relapse refractory setting.